today and our faculty, and I would like to express my deep appreciation to them for accepting my invitation and for their time and efforts. So joining us today are top speakers and worldwide very well-known figures in the field of neuromuscular ultrasound. And it's my pleasure that Professor Francis Walker is joining us. He's a professor of neurology at Wake Forest School of Medicine in North Carolina, USA. Joining us as well, Professor Michael Cartwright, professor of neurology at Wake Forest School of Medicine. Professor Nance Van Alphen, she will be joining us tomorrow. She is an associate professor of neurology and clinical neurophysiology at Radboud University Medical Center in Netherlands. Professor Peter Imben will join us shortly. He is an assistant professor of physical medicine and rehab at the University of British Columbia, Canada. And our eminent professor, our moderator today, the moderator of our course, is Professor Yasser Al-Midani, professor at Canterbury, Christ Church University, and King's College in London. It's really a pleasure for me to work with the esteemed faculty. I have known Dr. Walker and Dr. Michael Cartwright for about 7 years now. And I have been actually trained with them on neuromuscular at Wake Forest, so I consider them my mentors. And I have the pleasure to work with Dr. Nance and Dr. Peter as well in common research projects. So it's really a pleasure for me to work with them and to collaborate in this workshop, in this course. And I am honored really by their presence. I would like also to thank Medical Conference, the managing company. They have helped me in the management and preparation of this course. So thank you, Medical Conference. I will just give a very short overview over the course. The course is running over 2 days, today and tomorrow, as you know. And the learning objective and the curriculum of the course follow the guidelines, the published guidelines for neuromuscular ultrasound training, which has been published in Muscle and Nerve last year. And we like to follow the guidelines because it provides standardized training and professional training. So the learning objective and the curriculum are extracted from this reference. The course as well has been approved by the Federation of Royal College of Physicians of the United Kingdom for 6 credit points. And I will give you more details about the certificate and how you are going to get your certificate tomorrow at the end of the course. We have about 12 learning objectives in the basic course according to the guidelines, and we'll try to cover them as much as we can. So the lectures cover the ultrasound physics, the anatomy, the tracing of the nerves, optimization of the image, and the basic pathology, of course, including the basic intra-abdominal neuropathies. This is the program of the 2 days. I think that most of you have received already via email the PDF version of the program. But in all cases, I will attach the program after the end of this introduction in the chat box. You can download it. Just kindly note that tomorrow we'll start 5 p.m., not 2 p.m. Cairo time. So please convert your time zone so as not to miss the course tomorrow. And the next few slides, I will just pass through a few housekeeping tips. First, you can interact with us through the chat. You have 3 buttons at the bottom of your screen: the chat box, the raise hand, and the question and answer. If you have any problem with the video and audio, chat with us or raise your hand and the co-host will be glad to help you. For the questions, you can submit your questions in the question and answer box here at the bottom of your screen, and a window will open. You can see the questions raised by other participants and your question as well. We kindly just ask you to try to vote on the questions raised so that we can choose from them the most important. Because of the limited time, we have to pick the questions that we're going to answer. Every speaker will have will be able to receive your questions for 5 minutes after the end of each talk. And we'll try to have another half an hour at the end of each day. But please note that not all the speakers will be able to join us at the end of the day because of their busy schedule. But I will try to stick around as long as I can to be able just to answer your questions or any comments. Kindly note that we are recording the webinar, and I hope that it will be fully recorded. It will be available upon request after the end of this course, hopefully. And by this, I end my introduction, and I enjoy the course, and I wish you a happy time with us. Now we shall start our course, and Professor Yasser, the moderator, will present Professor Francis Walker, the first speaker with us today. Thank you.
Hello, everybody. It's my pleasure to introduce our first speaker, Professor Francis Walker. He's professor of neurology, Wake Forest School of Medicine, United States. He's an eminent, well-known figure who specialized in neuromuscular ultrasound ultrasonography, movement disorders, neuromuscular medicine, Huntington's and Parkinson's disease, botulinum toxins. He has pioneered the development of neuromuscular ultrasound as a diagnostic tool, and he is a worldwide expert of neuromuscular ultrasonography. He is the former president of the American Association of Neuromuscular Ultrasound.
I just lost.
Dr. Yasser, your voice is muted.
Okay.
Yeah.
Yeah. Do you hear me now?
Yeah.
Yes.
Oh, sorry. May I introduce Professor Francis Walker? He is going to speak to us about ultrasound physics and basic principles of neuromuscular ultrasound. Professor Walker is a professor of neurology, Wake Forest School of Medicine, USA. He's an eminent, well-known figure specialized in neuromuscular ultrasonography, and he has pioneered the development of the neuromuscular ultrasound as a diagnostic tool. He's a worldwide expert in neuromuscular ultrasound, former president of the American Association of Neuromuscular and Electrodiagnostic Medicine, editor of the neuromuscular ultrasound textbook with vast publication history in the neuromuscular ultrasound field. Professor Walker will speak today about ultrasound physics and basic principles of neuromuscular ultrasound. Professor Walker.
Oh, well, thank you. Let's see if I get that. Can you see my screen? Okay.
Yes, Dr. Walker, we can see it.
Very good.
Yeah.
So today we're going to discuss a favorite topic of mine, ultrasound physics and basic principles. I don't think it's critical that we understand all the details of this presentation, but I can assure you, as you gather more experience with ultrasound, a lot of what we talk about today will come in handy. Just a few things. Here we are. I'm at Wake Forest, and it's 8 in the morning here. And here's where we are. My office. I'm actually home, and it's about here on the map. And I would like to just mention to everyone that this kind of work can't go on without lots of help. And so you probably recognize some of my mentors. Bill McKinney was an ultrasound pioneer, but for carotid ultrasound. And he encouraged me to get involved with muscle, and it's taken off since then. And of course, you recognize a number of these people who have also worked with me. And the job in the world is for people like Dr. Kimura to help me get started, and then for me to help Dr. Cartwright get started, and then for us to help everyone else. And we do that with large teams. So thank you very much. Two very important sources of information. This, of course, we've written, and there's a small chapter on physics. Fred Kremkow works with us at Wake Forest and has a wonderful textbook for those who would like to know more. I'm not sure people need to study this topic in depth, but if you're interested, these are two worthwhile sources to get you started. So what are we going to talk about today? Well, we're going to talk about sort of how sound behaves in tissue, and then we'll talk about how we use sound to engineer this instrument. And we'll talk about some of the basic principles in this way. How much math do you need to know? And the good news is you don't need to know a lot of math to do well in physics. If you understand algebra, that's great. And if you're really interested in engineering, and we'd love for people that use the technique to improve the technology, well, then it's good to know some calculus and some other things. So let's talk about how sound behaves in tissue. So there are a couple key things that everyone has to realize that's unique about sound using ultrasound. The first is that ultrasound passes through different tissues at different speeds. And then the second is that sometimes as the sound passes through tissue, it generates echoes. And of course, that's what we see with ultrasound. Also, sometimes ultrasound diffuses and generates heat. And that was not terribly important these days, but when people in physical medicine and rehabilitation first started using ultrasound, it was primarily as a tool for heating things like bones and tendons. And so it's interesting technology, and it may come back to help us at a later time. But right now, we're mostly interested in the reflection or these echoes. So what causes reflection and why the difference in sound speed? And the key here is that every substance transmits sound at different speeds. And the simple rule is this: the harder the substance, the faster it conducts sound. So in air, sound travels about 336 meters a second. In water, about 5 times that at 1,540 meters a second. And in steel, at 6,000 meters a second. So in the old Westerns movies in the United States, someone would always put their ear to the railroad track to tell if the train was coming, because you could hear the sound much quicker that way than you could hear it by ear. If you're really interested, the material that conducts sound the fastest is diamond, because it's the hardest substance known to man. But I've never tested that myself, but just out of curiosity. So what about acoustic impedance? And acoustic impedance is a measure of sound conductance, right? So they're sort of interchangeable terms. So in humans, sound travels fastest in bone at 3,500 meters a second and slowest in air, as we said. And most of the soft tissue is about the same speed as water, because obviously most soft tissue in the body is made up of water. Well, it's not quite exactly right, though, because muscle, which is a little harder, one of the harder tissues, transmits sound at 1,585 meters a second, and fat at 1,450. So there are subtle differences in this acoustic impedance in most soft tissue in the human body. So what difference does this make, this acoustic impedance, or this ability to transmit sound? And the key is that echoes happen when there's a boundary between tissues or tissue elements where there is a change in acoustic impedance. And the amplitude of the echo that you see is proportional to the change in acoustic impedance. So sound can travel through, or it can bounce off, or most often it does both in soft tissue. So if the difference is large, there's a bigger echo here. If the difference is small, this echo becomes smaller. So for ultrasound to image tissue, it's good to have a lot of through transmission, right? We want to make sure there's plenty of sound in each different level of tissue that we go through for us to see it. And interfaces that reflect too much sound are a problem, right? And so that's the reason why we put coupling gel on our transducer, because that keeps all the energy in our transducer that takes it into the tissue below. Without the coupling gel, you don't get good transmission of sound because there's an air barrier and a skin barrier. And we also know that if you try to image through the lung or through bone, you really don't get an image of anything deeper. There's way too much reflection of the sound energy for any to pass through. And soft tissue is wonderful because it has enough small interfaces that it creates echoes, but not so many tissue planes that are different that it allows most of the sound to get through. So that's our little theoretical introduction. Let's get down to the picture. What's it look like? Well, I think it's easiest to understand in muscle. This is a cross section of the tibialis anterior muscle. And I typically look at this image first. This is the cross section. And what we see is that this is the aponeurosis, and this is muscle tissue with fibrous tissue. And if you just look at this image, it's a little hard to know, but when you look at it in a long section or sagittal view, what you can see is this is a bipinnate muscle with a central aponeurosis. And what we see in cross-section are all these fibrous planes of the epimysium and the paramysium that join to the central aponeurosis. If we follow the aponeurosis distally, we eventually get to where it turns into a tendon. So the first question is, well, does the aponeurosis have a higher or lower acoustic impedance than the surrounding muscle? And the answer is, well, it's got to be higher. It's fibrous tissue, and it's slightly harder than muscle. And that's why it creates the echo at that spot. And it's interesting, muscle tissue itself is homogeneous, and most of the sound travels through. And what you see when we do ultrasound of muscle is the fibrous tissue architecture of the muscle. And because the muscle itself, you don't really see, it's black, but the fibrous tissue is what stands out as white. So let's talk about attenuation. Okay, so this is incident sound waves. Some of it gets reflected, some of it gets transmitted, but some of it also gets absorbed, okay? So as sound passes through tissue, it gets weaker, right? So at the surface of the skin, it's a very powerful sound energy, and then as it buries itself into the tissue, it gets less and less and less. And that's because there's reflections and there's absorption. Now, when it gets absorbed, that turns into heat, which generally is quite low for most routine ultrasound. But nonetheless, these are the two processes that happens. And again, some energy is lost through absorption, some is lost through reflection. And so attenuation is the incident sound energy minus the transmitted sound energy. So what you lose over space is attenuation. So very simple equation. Why is it so important? Well, it has a significant impact on the amplitude of echoes, right? So as sound energy travels through tissue, it becomes less. And the amplitude of an echo from a shallow structure is going to always be greater than the amplitude from the same structure, even if it was located deeper. But rather than get into details about this, we can correct for it, and that's what happens in the instrument. We'll talk about that in a minute. And it's important because echo intensity gives us some idea of what's going on in the tissue. We know that if you see an object that has a very bright echo, then that tells us it's something different than something that has a smaller echo. So how do we use this physics to create images? Well, let's talk about A-mode imaging first. It's the simplest type of ultrasound. And what I want to emphasize for those of you who have a background in electrophysiology is that both ultrasound and EMG began with oscilloscope technology. And these instruments are at Wake Forest. They're in our ultrasound laboratory, and that's what we started with when we first started doing ultrasound. And when I say we, I wasn't there. It was in the 1970s. But those are the instruments that we used. And you go, well, wait a minute, how does the oscilloscope create sound? It's just an electrical device. Well, it's really very simple. You just need a transducer. So there are certain chemicals, there's ceramics and crystals, that if you apply an electrical current, it kicks the energy of the electrons into a different orbit. And when that happens, there's a shape change in the atom. And if that happens in every atom in the transducer, you get a shape change in the transducer. And that subtle shape change generates a sound pulse. Okay, so it's basically a little trick that you put in between the electrical signal that creates sound. And then if the sound hits the transducer, it creates an electrical signal. So the early A-mode images, we would just send out one pulse of sound. It was like a ping from old sonar. And the transmitter would wait and pick up the echoes that came back from that one ping, and then we'll convert them to electricity. And just like EMG or nerve conductions, the latency was displayed on the x-axis and the amplitude on the y-axis. So those of us who are used to EMG are very familiar with A-mode ultrasound. And here's an example of a very early A-mode ultrasound. And of course, by looking at this picture, you know exactly what we're looking at, right? Well, maybe not. Let me help just a little bit, but it makes perfectly good sense once we clear this up. So here's some indistinct echoes. Here's a spike. Here's another spike. And here's the last little spike, okay? I've spread it out just a little bit. But what this actually was is an image of a baby's head in utero, right? And so what happens is, just think of one line of data here. And what you get is, well, as it goes through the abdomen, you get little echoes. and then it comes to the amniotic fluid, and there's no echo. Then it hits the baby's skull, and here's the spike, travels through the brain, hits the back of the skull, boom, another big spike, and then here's the amniotic fluid in the uterine wall. So that is A-mode ultrasound, and lines up very nicely if you do it this way. And you can see there's a trick to doing this. So here we are, abdominal wall, skull, skull, abdominal wall. And this is the amniotic fluid. So why don't we use A-mode anymore? Well, it's because it only captures a single line of data. There's a limited internal reference. So you really don't know exactly what you're looking at. You don't have any way of checking what you think you're supposed to be looking at and what you're actually looking at. And so it's a problem. So how did we get to B-mode imaging? So this helps. So let's talk about ultrasound of the orbit here. So this is the old classic ultrasound. This is an A-mode image when you go through the orbit. And again, just like when we looked at the baby's head, it's kind of confusing, right? But here's the picture we like, right? Here's, this one's got a little vitreous hemorrhage, and we can see the lens in the back of the eye. So the key here is to take an A-mode image. What we want to do is compress the image so that amplitude is represented not by deflection, but simply by brightness or darkness. So if there's no echo, we make it black. If it's a huge echo, we make it bright white, and then everything else is shown as shades of gray. So here it is. Instead of doing this one line as A-mode, but we could all push it into one line of data this way, right? So where there's a spike, it's white. Where it dips, it changes color. Here's another spike, and here it goes. And so you can represent all the data shown here on this one line just by varying shades of gray. And once you do that, you can superimpose multiple lines of data. And it's very hard to do that with A-mode, but once you compress it, then you can superimpose everything. This line of data is just one of many that goes to make up this whole image. And that's the secret of ultrasound. And how do we do it with a real transducer? Well, here it is. The transducer is not just one thing. It's multiple little bitty transducers, all attached to wires. That's why this cord, by the way, is so thick. And it creates this beautiful two-dimensional image with time. And well, that's interesting. Can we do it with EMG? And the answer is, well, you actually kind of can. So this is Eric Stahlberg, one of the world's pioneers of single fiber EMG, fantastic educator and scientist. And here he is doing macro EMG, and he's pulling the EMG needle through a muscle, and you can see how the motor unit that he's recording over and over again looks different as he moves the needle through. And so it's sort of a superimposition of multiple A-mode type pictures. It's tricky. You can do it even in a different way. You can wire up the face to record how muscles record. And here's a picture sort of like a combined image that we would do with ultrasound, and you can see the diffusion of contraction of facial muscles when you stimulate the facial nerve. It's not very satisfying though. And why isn't it? It's because we don't know where the anatomy is. All we see is the function in this image. And so EMG remains a tool that we use with basically an oscilloscope, whereas ultrasound creates us these beautiful three-dimensional images. Now, how do we figure out depth, right? And so the idea is that the latency of the returning echo provides a fairly accurate estimate of how deep something is in tissue, right? So we know that this is part of the baby's skull and this is the other side. And we have a pretty good idea of how fast sound travels in tissue, which is 1,540 meters a second. Well, then we can estimate this distance very accurately. Now, it's not precise, but it's a pretty good estimate. And so what we do is we assume that sound travels at this speed through all soft tissue. Well, it's not exactly right though. And I just want to remember, you know, if you're an engineer, you'll settle for good enough, right? Not everything has to be 100%, but we do want it to be as accurate as possible. But the truth of the matter is that sound travels a little slower through fat, so it tends to slightly underestimate its thickness, travels a little bit faster in muscle, so it tends to slightly overestimate its thickness. And the important point here is that the way to remember that is it makes you look a little buff, right? It makes you look a little better than you really are. Your muscles look a little bigger, your fat layer's a little thinner. So it's not a big difference, but I just want to keep in the back of your mind that ultrasound creates a virtual image that's an estimate of what's going on in real tissue. It's a very good estimate, but it's not a perfect estimate. How do we deal with attenuation? Now, if you remember, we talked about attenuation, that the sound wave dissipates over time. And so theoretically, this first A mode spike and the second A mode spike should be different. This one should be smaller because there's less energy. Well, we figured out a long time ago that you have to cheat a little bit when you generate an ultrasound picture, because what we do is we estimate, well, gee, this sound wave, let's say, lost 50% of its energy as it traveled this far. We'll just double the size of this particular spike. So there's an amplification that goes on over distance. This process, it's wired into every instrument, is called time gain compensation. And they engineer to amplify echoes that come back later to make them equivalent in scope to the ones that occur nearer, so that when you look at an image, all the echo intensities are sort of compensated for because we know the sound energy is less in the deeper parts of the tissue. Now, this is a little complicated because every instrument company does this. To compare the echoes from one instrument to another, they won't be exactly the same. But manufacturers realize that sometimes we want to mess with this ourselves. So there's many instruments come with these little panels where you can adjust depth gain control or the time gain compensation. We use those sometimes to help us. And I think our next speaker, Dr. Inkpen, is going to talk to us about how to use these knobs. But here's a quick example. We can put the high amplification at everything near, and then you don't see very well what's going on deeper. Or we can adjust it so you see everything well in the depths, but not so well in the near field. There's more tricks to it than that, but I just want you to understand that this is, to make this beautiful image, we have to make sacrifices. And I will say is that I really want to go, then it's really much easier to do on A mode than on B mode, right? Because you can say, oh, this many, it's like measuring a nerve conduction study. But that's okay. And then the problem with vision, the question is, well, why is it that we can't measure echo brightness so well? And the answer is, we just don't see brightness as accurately as we see height. And so if we look at an A mode image, we really get a feeling for the amplitude of the echoes. But when we look at a B mode image, it's harder. And let me give you an example. So here I am right here. I live in a little city. I don't live in a big city, right? This is a bump map showing the population of different areas of the United States, right? Here we are. And when you look at this, you can say, oh, gee, that's 20, 30, 40 times bigger. But if we go to a brightness map of the United States, and this is the same thing, this is population density expressed as brightness, you could see the same thing from a satellite at night, right? Because this would be light intensity. But it's very hard to say, well, gee, how much brighter is this one than this one? Or if you live in Chicago or Atlanta or New York, right? So our eyes are designed as human beings brightness doesn't matter that much, right? If it's a bright day, a dark day is sort of, when we take photographs, we're always confused because we can never get brightness right because our eye even cheats, right? We've got a pupil that constricts. Height, though, we're really good at picking up about height, right? Because it really makes a big difference if you're seeing a fellow primate, how big that fellow primate is, right? Is this a threatening primate or is this a friendly primate? So our eyes are sort of wired better to see amplitude if we want to measure something. But for ultrasound, it really helps us because we get these beautiful images. So A mode provides a more precise measure of amplitude. B mode gives us a much better definition of anatomy, and that's really what we want. And, if you think about EMG and nerve conductions, amplitude is just one of many variables, particularly in EMG. The amplitude is sort of a motor unit, depends really on how close your needle tip is to that motor unit. And things such as frequency, latency, firing pattern, duration, and morphology are often more important than amplitude. But it's a trade-off. As we went from A mode to B mode, we don't really get the precise measures that we could have gotten before. But we can still measure amplitude, right? We're really good at measuring size with ultrasound, and here we are measuring the median nerve. I think we'll get a nice discussion of that later. But you can take a piece of muscle, either the whole muscle or a little piece of it, and you can run it through these programs. Now you have to do this offline, but you can get very nice measures of what we're seeing in terms of brightness and echoes by doing it this way. It's sometimes useful, but it's not part of all ultrasound instruments. We have these quantitative motor unit programs in a lot of our EMG machines, and many of us, I'm probably guilty, I don't use it very much. It's a very interesting device, but it's labor intense and time intense, and often we don't take the trouble to use that. And on our own to make judgments about the tissue and just things to understand about what we do with ultrasound to help us know how to use it better. So remember, ultrasound creates a virtual image. It's accurate, but not 100% precise. And understanding these physics helps you account for any differences. Now, let's be a little more practical and talk about how does this present in real time. And here's an example of normal muscle. And the question is, why do we see it that way? And the answer is, well, highly organized tissues or structures transmit sound, and disorganized tissues reflect sound. So here's muscle histology that shows you very nicely this pattern of organized Z lines, A lines, all that. And this is fibrous tissue, which is tremendously disorganized, right? That's the structure of collagen. If we dissolve muscle tissue out of muscle, it leaves this fibrous tissue framework. Now, this is not my work, but it's a beautiful article in Muscle and Nerve showing you all this fibrous tissue. And when we do ultrasound, this is really what we're seeing. This is a cross-section of the epimysium and the paramysium. And that's why we get this image, right? So remember, healthy muscle transmits sound, kind of like a quartz crystal. The fibrous tissue, a collagen, reflects sound. Like if you have a diamond with an inclusion in it. And heavy muscle, healthy muscle is either very black or very white. Now, what happens when you get diseased muscle? Well, this is the first example I saw, and you'll get to hear from Nens van Alphen later, and she's fantastic and talk about modern ultrasound imaging of muscle, but this is the first time I looked at it. And this was my biceps. You can see the humerus nicely. You can see the biceps. You can see black versus white, not with the resolution we have today. And this is a patient with polymyositis. You can barely see the bone, right? And then the muscle has become sort of this homogeneous and very echogenic substance, right? And why is that? Well, this is the biopsy from that very same patient, not from that muscle. This was from the quadriceps, that was the biceps. But here we see all this pathology, right? You see necrotic, dying muscle fibers. You see lots of inflammation. You see fat. You see fibrosis. And you see necrosis. And every time the sound waves hit this stuff, it bounces off, right? Because you don't have that homogeneous, healthy muscle tissue. And so that's why we see all these echoes. It becomes more homogeneous as the architecture is disrupted, and more sound is reflected, and less is available for deeper tissues. And that's why we really don't see the bone edge so well. The machine thinks we should have a lot more energy hitting that bone than actually is. And so it may be sort of an artifact of the procedure, but in any case, it gives us this very characteristic image. And in addition to that, we can see that the muscle has become thinner, right? So Heckmatt and Dubovitz in 1978 began describing these changes. Atrophy, echogenicity is increased. The muscle can be more homogeneous. You lose the bone edge. And I don't really want to get into the differences between myopathy and neuropathy. NENS will talk about that. But the notion is ultrasound is a very powerful tool. And when you think about the physics, it makes sense that it's very good at picking up things like muscular dystrophy. And what about nerve imaging? Well, nerve imaging came later because we needed much higher resolution instruments to see nerve. But they're very similar principles. There are areas of the nerve that seem to be more myelin containing, and those would be the fascicles. And then there's the perineurium and the epineurium, which is more fibrous tissue that we can see. And that shows up on ultrasound as well. This is a very unusual instrument that has ultra high resolution. This is a 50 megahertz probe. And what you can see is the same architecture in the nerve. But we've come to nerves a little later than muscle because we needed higher resolution instruments. And so really that has only been in the last 20 years that we started really looking at nerve intently. Anisotropy. So we'll learn more about nerve imaging later in the course, but just wanted to get your thinking about, well, what's the physics behind that? So the last thing I want to talk about in physics is anisotropy, right? Which is a big word, but it just means that different tissues reflect sound differently. Some backscatter light sort of all over the place, and others reflect it more like a mirror. So what's a mirror-like tissue? Well, a tendon. It has very high anisotropy, and it maximally reflects sound when the transducer is perfectly perpendicular to the tissue of interest. Now, if you're looking at a backscattering tissue like fat, it tends to backscatter reflections equally in all directions. So it doesn't change as much as you change the angle of insonation. Right. So remember, you aim your sound, and if you hit a reflecting surface, if you hit light or sound, it'll come in and bounce off at this very specific angle. Here's an example with a laser pointer, and we may have all done this with a mirror, which is you get this angle where this angle and this angle are equal. But if you shine a laser pointer on a wall, it scatters, right? So the cat sees it, you see it, everybody in the room would see this very bright dot. And that's backscattering, but the mirror tends to reflect most of the energy off in one point. So that is a tissue property, this ability to reflect. So this is called specular reflection or high anisotropy, and that's like a tendon. And this is diffuse reflection, more like muscle or fat, where the sound bounces off in different directions. Let's give you an example. This is a little tricky. This is a tendon and a nerve. If we shift the angle of incidence, just tilt the probe just a little bit, that tendon becomes dark right away. The nerve doesn't change as much. All right, and we'll show you another example of that in a second here. So we're going to do the same thing. So this is a cross section of the median nerve at the wrist. So the probe is exactly perpendicular to the wrist, and we're looking at a cross section of the carpal tunnel. Nerve here, that's the median nerve, and these are the tendons. Okay, now we'll run this video, and as I close my fingers and bend my wrist, you can see that the anisotropy of these things, right? So here we're perfectly perpendicular. You see how bright the tendons are. If we shift just a little bit, oh, you can see the nerve move, which is fun. I'll learn more about that later. But as the tendon moves as the angle of the transducer shifts a little bit, you can see that things can change a little bit in terms of their intensity right there, okay? So what happens is, if you're not perfectly perpendicular to those tendons, here, it's dark. The nerve looks pretty much the same. And you can see, boom, right now we get the tendons right in focus. So that anisotropy is very helpful for us in distinguishing nerve from tendon. This makes a lot more sense when you're doing it yourself, but I just want you to understand that this is an important principle. So remember, when you're trying to measure intensity, you want to be perpendicular to you want your transducer probe to be perpendicular. And what you do is you sort of adjust the angle of your probe until you get the brightest looking image. You have to really practice. That's very different from using a stimulator or an EMG needle, right? Because it doesn't matter in EMG which angle you attack the muscle from. It's only recording from the distal tip. If you're stimulating a nerve, it doesn't matter how you point the stimulator. It only matters where it contacts the skin. But for ultrasound, that angle is very important, and that takes skill and practice. Okay, let's ask a few questions. In soft tissue, is most sound reflected or is most sound transmitted? And I'm sure you know the answer. We already talked about it. Most is transmitted because the difference in acoustic impedance in soft tissue is quite small. No matter if you move from tissue to tissue, most of the sound still goes through. There aren't interfaces of things that reflect too much. And it's really only where soft tissue abuts bone or air that you lose sound transmission. Can't see through the lung, and you can't see through a bone. The nice thing with ultrasound is we can just change the position of the probe and go to the other side. So other than trying to look in the chest cavity, we can see most of what's in the human body that's important. Of course, can't see much in the brain unless you've got a baby and you look through the fontanelle. What happens if there's calcification? So there are a number of things that cause calcification in tissue. Myositis ossificans comes to mind. And right, here's an example of somebody who had traumatized their deltoid and developed small calcium deposits. And so what happens is you don't really see a normal, healthy looking deltoid here, but we see this little band of calcium and it casts a shadow, remember? So that's what we see. And it's called acoustic shadowing, and it happens deep to these calcific deposits. What happens if there's a cyst? Right, so let's get back to this. So remember, the ultrasound instrument, so much is reflected at this calcium. This is an example where not enough sound is getting through. So the machine rightly estimates loss of tissue of sound energy here, and the image is fairly straightforward, but here it's assuming that there's more energy. And so, but there's nothing going through here. So it turns out to be black. So acoustic shadowing is the result of the instrument's interest in it. The instrument corrects for attenuation, but here it undercorrected because there's so much more attenuation that happened. And if you're a clinician, you'll know that that must be the cause. What happens if there's a simple cyst? Well, here's an example of a ganglion cyst, right? And you can see this tendon underneath it, and it's much brighter under the cyst. And why is that? Well, the machine assumes that you're losing energy as you go through this fluid. But of course, fluid transmits all the energy, whereas the tissue reflects a little bit. So when you get over here, this piece of the tendon is getting more sound energy than this piece of the tendon. which went through soft tissue. And so the machine amplifies this the same way it amplifies this, but this one's brighter because there's more energy. So we call this acoustic enhancement, and you'll see that deep to fluid filled structures. So, right, if you go through cyst, or if you go through actually a large blood vessel, there isn't much energy lost. And so you'll often see a slightly brighter echo deep to these things. Important to understand acoustic enhancement. We call it an artifact, but really it's an intrinsic property of ultrasound in human tissue that helps us understand what we're looking at. So here's an example of us doing an image of the biceps. And we put the probe perpendicular to the biceps, one of them, and the other one is slightly off perpendicular. And the question is, well, which one of these is most perpendicular for the probe? And the answer, of course, is this one, the right image, right? Because here we see this, it's brighter. And so that tells us, oh, well, you must be exactly at 90 degrees. And if you wanted to measure echo intensity, this would be the image you would choose. And again, here's the biceps. This is the subcutaneous tissue here. Transducers. Okay, let's talk about transducers for a minute. This is a small footprint transducer, and it gives you a smaller image than a large footprint transducer, right? As a rule, we like these bigger footprint transducers. They show us more tissue, and so you get oriented quicker when you use them. But this is really nice if you go around something hard and bony, because it's got a little contact area, and the bones don't push it out of the way as you try and go around the ankle or over the wrist. The width that we see on ultrasound is probably more accurate than the depth, because, right, we're making estimates of how fast this is traveling through tissue to come up with depth. Depth is still pretty accurate, but the width has to do with the width of your instrument, and that is a little more precise. What else about transducers? Well, if you have a high frequency transducer, it tends to have better resolution, but poor depth of penetration. And so if you're interested in nerves, we want super high resolution probes. That means higher frequency probes. For muscles like the diaphragm, you want lower frequency transducers, and they have a better depth of penetration. So if you're trying to insert a needle into something and it's very deep, you want the lower frequency transducer so you can see deeper into tissue. The way to remember that is the sound of thunder, because thunder comes from lightning, and if it's far away, all you hear is the low pitch, right? But if it's close, you hear the thunder clap, or a very sharp, high-pitched element. So it's actually the frequency of the sound tells you something about how far away it is. Low frequencies go better through distance than high frequencies is the rule. So why do these transducers cost so much? Sort of odd question. Well, we just showed you the engineering. It's quite a feat, right? You have all these things lined up. You got all these wires. And a typical transducer in United States dollars is about $5,000. It varies a little bit from instrument to instrument, but that's nothing to sneeze at. But if you think about all the work it saves you, if you look at what we have to do every time we change a nerve or change muscle, we have to move all these things around when we do EMG or nerve conduction studies. With ultrasound, just pop the probe on and off you go. So I would argue it's a fair trade. The engineers did all the work in ultrasound for us. That's very nice. Focal zones. Right, so if we use a CT or an MR, the resolution at this point and this point and this point all through is the same. It's like it's equal thickness throughout. It doesn't really work that way with ultrasound. Turns out that as you use your ultrasound beam, it has a thinner point. So if you think of it as a voxel, there's an area where you get less averaging artifact, and that's at the focal zone. We can adjust that with the machines. Again, Dr. Inkpen will talk to you a little bit about that. And often when you're looking at something small like a nerve, it helps to line up the focal zone with the interest, with whatever you're interested in. But it's important to understand something else about these focal zones is you can increase the number of focal zones and you can adjust your image. There are tricks on the machine that give you better spatial resolution. You can average it more, there's more persistence. But the more you do that, the less temporal resolution you get. So you get there's a trade-off, and we talked about that with ultrasound. And so if you focus too much on temporal resolution, on spatial resolution, on getting a nice quality image, you might lose a little bit of the ability to image change over time. I just wanted to remind you that this is a real thing. This is where I put in multiple focal zones, I've averaged, I'm persistence, everything's way up on the machine to give us a better image quality. But now I'm just twitching the muscles in the foot, and you can see it's an odd picture. Oops, let me back that up. Things are averaged. You can kind of see how problematic that is. Now, we can take all those special fancy things off, and then we can see this twitch. This is the way the twitch really looks like, and you can see the difference. It's not often important that we care. This is manifest as frame rate, which is displayed on your instrument. But I just want you to realize that can be an important thing as well. So the question is, which transducer is better for doing the dorsal cutaneous nerve of the dorsal ulnar cutaneous nerve? Do you want a 10 megahertz large footprint transducer or an 18 hertz small footprint transducer? Well, the answer is right. We want the small footprint because it's very bony here around the wrist. And you really want the high resolution because it's a little tiny nerve. If we had asked about the sciatic nerve, that runs deeper, and then you might want to use a 10 or 12 megahertz probe for that. When is it most helpful to have high temporal resolution or high frame rate? When you're looking at blood flow or when you're looking at tongue fasciculations? And the answer is right. Things like tongue fasciculation, super quick. You really want to make sure your frame rate is set so that you can pick up any change very nicely, which is more helpful for distinguishing a vein from an artery. Adjusting the pressure of the transducer, which means how hard you're pushing on the skin, or adjusting the transducer angle. And of course, in this case, it's actually the transducer pressure. Veins collapse easily. Arteries, you have to push a little harder. And so we didn't really talk about, I'm not sure where this is in the physics talk, but right, how hard you push on the transducer sometimes makes a difference. Which shows more structural change when you rotate the transducer 90 degrees, fat or muscle. Now, I haven't really shown you much subcutaneous fat in these, I mean, there's a little bit in these images, but we've shown you the muscle. And of course, muscle is the one that changes so dramatically as you go to a cross-section from cross-section to sagittal section or long axis. Which is most helpful in distinguishing a nerve from a tendon? Is this rotating the transducer 90 degrees, like we just did with the muscle and the fat, or changing the angle of incination with the transducer angle? And here, the answer is right. If we change the angle of incidence, right? Dr. Strakowski likes to call that toggling. I'm not sure what to call it, but you do. It's the one skill that doesn't come easily to those of us who have done EMG and nerve conductions, because it doesn't matter when you do nerve conductions or EMG, but it matters a lot doing ultrasound. Which tissue is more likely to create acoustic shadowing? Dense fibrous tissue or a lipoma, right? And then you have to know something about clinical medicine, but you're like, oh, what absorbs more energy? Well, that would be the dense fibrous tissue. And so you'll get a shadow. It won't be as dramatic as calcium, but you'll get, it'll be slightly shadowed below fibrous tissue. So, well, here's another question. Well, will there continue to be technological advances in ultrasound? And again, this is a little bit out of the lecture, but the answer is, well, let's look at this. Here's EMG. This was done in 1950, right? This is an EMG from today, as it were. Well, actually 2016 is when I made this image, but it doesn't look any different. Really, the only difference is in the modern instruments, we put the dots on the screen. In this day, we were using a sine wave. So EMG hasn't really changed that much. Boy, ultrasound sure has, hasn't it? This is the baby, this is the fetus in 1953, and this is today. And the reason why ultrasound has changed so much, and imaging in general, is because of Moore's law. Right, and so this is one of those things that show you that you can get more transistors on an integrated circuit chip, or how many bytes of information you can get per square inch, and it's logarithmic. And this is what has determined the advances in ultrasound. We haven't quite figured out how to use this in EMG, so if any of you are really smart and can do that, please do. Let's draw some conclusions as I'll wind up. Different tissues transmit sound at different speeds, and acoustic impedance characterizes this tissue property. And it's differences in acoustic impedance at tissue interfaces that determines how bright an echo comes out. Different tissues reflect or backscatter sound in different ways. And this is anisotropy characterizes this tissue property. Tendons look different from muscle. If you've ever had an ultrasound and you're wondering why the technician is moving that probe around so much, it's because they want to see this anisotropy. And different tissues reduce sound energy to a variable extent. And so this is attenuation, and you have to understand that as well. So those are 3 A's, as it were. And then all ultrasound involves trade-offs. B-mode imaging sacrifices precise measurement of echo intensity for good definition of anatomy. High frequency transducers sacrifice depth for spatial resolution up close. Small footprint transducers sacrifice width of view, but they're much easier to use around bony structures. And the use of multiple focal zones, averaging and persistence, sacrifices temporal resolution for spatial resolution. So there's always tricks in ultrasound to help, but there's always trade-offs as well. Ultrasound physics, if you can understand that, you'll get better at imaging. And it really helps to have trial and error. I found ultrasound, I understand physics much better having done ultrasound than the other way around. And we encourage anyone who's using or practicing ultrasound to come back and look at this physics business again, in 4 to 6 months, at least once or twice as early in your career, because it really makes more sense, and then it'll really help you move forward as you use this technology. Now, if you believe in Moore's law, we know that ultrasound technology will continue to evolve. And it will continue, by the way, to stay one step ahead of MR and CT in terms of resolution. It has, obviously, MR and CT have other advantages, but just remember, this is going to continue to evolve. And so my final argument is this is a great time for you to start using ultrasound, because there's going to be more discoveries in the future, and we all want you to be part of it. Thank you very much.
Thank you, Professor Walker. It was a lovely and interesting talk. I can see the feedback is coming absolutely positive.
Good.
Well, there was a question about what are the uses of M-mode in neuromuscular field?
That's a very good question. And M-mode, we don't use that much. We use it sometimes to study diaphragm movement, and it's very helpful. And it can also be used to study fasciculations. So if you're interested in the duration of a motor unit contraction, ultrasound is a wonderful, M-mode is a great tool for doing that. You can also use it with a supramaximal stimulation and look at the duration of the entire contraction of the motor unit. Up until now, we'd have to use these strain gauges, and we could do it with an oscilloscope. But with ultrasound, it's very easy. But in general, we use M-mode just a little bit. But I'm hoping that somebody, maybe the person who asked this question, has got some great thoughts about how to make use of it more. So that's what we hope.
Yeah, excellent. There was another question. If I'm buying an ultrasound machine for neuromuscular ultrasonography, what type of probe shall I get? Shall I get the small footprint or
Well,
the money?
Yeah. So the good question is, if you're interested primarily in neuromuscular ultrasound, you want the highest resolution probe you can get your hands on. And most instruments, that's going to be 15 to 20 hertz. Now, in some instruments, the 15 megahertz probe is better than a 20 megahertz probe in a different instrument, because it's not just the transducer, it's also the instrument. But you want to get that. And I actually don't mind the smaller footprint ones, but if you can get a larger probe and it's doing as well as the smaller probe, that's good too. If you get a second probe, then you want one that's got a little bit lower range, and that'll help you with looking at muscles and deep structure. But that adds to the cost, and so it's remember we said everything's a trade-off. Good luck.
Well, I cannot see any more questions.
Okay.
Iman, can you see anything on your side?
Yeah, I can see one question. Can we use the spectral Doppler twinkling further for specific tissue pattern?
I'm sorry.
Someone asked me about the spectral Doppler twinkling for a specific tissue pattern.
Yeah, two questions there.
Spectral, can we? Yeah, you can see the question and answer. You can see it. Just to click on the box.
Yeah. Well, there is a question. Can we use spectral Doppler twinkling further for specific tissue patterns?
Yes. Doppler is interesting. So I didn't talk much about Doppler physics because it's not a huge part of what we do with neuromuscular, but we use power Doppler to look at blood flow in nerve. And now there are ways to use Doppler imaging to pick up things like fasciculation. So there's some very interesting work going on there. And again, I think it's part of the technology that hasn't been used to its maximal benefit. So I'm hoping that, again, it's like EMG and nerve conductions in that the more people use it, the more the rest of us learn about it. So please, if you've got some good ideas, go for it. And if you want to send me, if you have questions, I'm sure Iman will share my email and happy to answer those in more detail.
Another question, do you recommend portable machines?
Yes, I actually, nowadays, I mean, it's great. There's some really large instruments that are tremendously expensive, and if you can afford it, great. But I like the portable machines that we go from room to room, because we have several EMG machines, and we go take it upstairs to see patients in the intensive care unit. So portability is great. And if you, there are some wonderful instruments that are portable, and just check it out and look at your budget and look at what your needs are. And please get started. The more you do, the better things go.
Excellent. I have no more questions on my side. Thanks so much, Professor Walker.
All right.
I look forward to meeting up with you again at the end of the day.
Thank you. Bye-bye.
Thank you so much. Thank you. Well, it's time now to move to our next talk, and Professor Peter Inkpen. He's Associate Professor, Physical Medicine Rehabilitation at University of British Columbia, Canada. He's a worldwide expert in neuromuscular ultrasonography and one of the only few providers in Canada with neuromuscular ultrasound skills. He's specialized in physical medicine rehabilitation, electrodiagnostic medicine, neuromuscular and ultrasound, ultrasound, certified international pain sonologist with a long list of publications in neuromuscular field, and is actively involved in teaching and training. He will speak today to us about novology, image optimization, and principles of peripheral nerve scanning. Professor Inkpen.
Okay, I hope everybody can hear me. Looks like we're ready to get going. Thanks very much for the introduction. I feel a little nervous seeing the participant list. You always stand in front of a big audience and never really think about the numbers, and we're at least 200 here today. I appreciate it very much. Let's start with share my screen, and here we go. I'm just going to ask the organizers to send me a little message to make sure that the screen is
Yeah, the screen is fine, Dr. Peter. It's really, I
awesome.
can see. Yeah, thank
Excellent.
you.
Okay.
Thank you.
All right. Thanks, Eamon. I've got my coffee. Sorry for the noise earlier. That was me. I just, it's early here in Canada. And I usually have about 3 lattes before I start clinic in the morning. So I'm still waking up a little bit. Let's get on with the lecture. I practiced this one yesterday and I came in just under 30 minutes. So I'll try to do the same. I'd like to thank Francis for his lecture as well. So we're going to talk about some knobology, which is really a clumsy term to describe what the knobs and buttons do on an ultrasound machine. I'm going to optimize some images and talk about general principles of scanning. I have no conflict of interest. We're going to start with just looking at the machine itself. And so this is just a picture of a general console-based ultrasound machine. This is a semi-portable machine. I say semi-portable because it's big and clunky and you got to power it down to move it around. But we've got a monitor, a touch screen, a console, and somewhere to place the transducers. The transducers are also called probes. It's interchangeable. And just a little introduction to how the nomenclature works on the ultrasound itself, or on the transducers themselves. We can see that we have this one, which is a 15-6. The standard is that the high frequency is first. So this transducer is 15 megahertz and it goes down to 6. The other transducer here is 5 going down to 2. So this is a picture of just a general console. This is actually a picture from one of my machines. And I've kind of labeled and circled some of the more important buttons and that. And each machine is different, but the general principles here are you need something to adjust the image, something to label the image, and something to save images and video. Now, in ultrasound, video is also called sine loops, C-I-N-E, and that's ported in from an old the historical components of where the loops came from. But anyway, we're going to call them video. On this machine here, we've got a power button, which I cut off up in the top left, something to sleep it, and we've got several buttons on the top and on the side. The most important one is going to be your 2D button. So this is to switch back and forth from color to 2D or B mode. And so we push the button to go into 2D mode, and then we turn the dial or the knob to increase the brightness of the entire picture itself. And because ultrasound is like our sound waves, we can consider it very much just like audio. So in the world of audio, we increase the gain of an audio mix, and we decrease the gain, and that increases the volume and decreases the volume respectively. And it's the same thing with ultrasound. So if volume is like brightness, then we can increase the volume or increase the brightness, and decrease the volume and decrease the brightness. This is the color button. We're not going to talk in detail about color today, but at a later course, we'll dive right into it. Color is the same thing. We can increase the brightness or the intensity of the color image, which leads to some artifact or improvement of or enhancement of the image itself. This is these sliders here, the time gain compensation sliders. I'll talk about that in a second. On the right side here, we have depth and then focus. Now, depth increases the depth of the image or decreases the depth of the image, and we want to optimize our image so that we're using all of the screen. The focus here, we can move the focus up and down. Some machines do not have a focus button. I'll show you a machine like that in a moment. The focus here, the knob moves the focus up and down the screen itself, and then you can add a number of foci. Now we want the focus in the area where our target is, and I'll show you that in a second as well. The zoom button here is helpful for the far field images, so deeper structures, and I'll touch on that when we do the nerve scanning lecture. And then in this machine, we have 3 buttons, acquire 1, 2, and 3. And they're really just ways that you can save images. So I've got it set up so that acquire 1 is a video, acquire 2 is a picture, and I don't think acquire 3 does anything. Freeze is always an important button because we want to stop, look at our image. We want to stop, label, measure, and save images as well. On this one, we have measure, label, and then additional buttons. These knobs up here are just for other things that happen in the touchscreen, but we won't go into that today. Okay, so here's a completely digital touchscreen interface. And on this machine here, we don't have the same kind of buttons and knobs. What we have is all touchscreen. So we have a 2D touch, a color touch, Doppler and M mode, buttons that are labeled, save video clip, freeze, etc. And then we have a slider on the right side for moving the depth. We can zoom with a button, we can label with a button, and we have this auto button here, which helps to just optimize the image, although I've never pushed it myself. Here's a slider for gain, and you can see here they really kind of hit home this point that if you slide it to the right, makes the image bright, slide it to the left, makes the image dark. So the key with all ultrasound is first you have to choose what target you are aiming for. So what are you really looking for? If you're looking at the ulnar nerve in the forearm, then what we do is we choose a transducer and the preset based on it. Now I'm going to step back a little bit. As Dr. Walker mentioned, the higher frequency transducers are better for superficial imaging, and lower frequency transducers are going to have deeper penetration and better for deeper images. Within each transducer, you can have certain presets. Now the presets really are about dynamic range, gray maps, and echo intensity. And what I've done in my clinic is I've really set one preset per transducer. I've messed around with this over the years, made presets for nerves and small parts and nerve 2 here, and then I just finally just said, okay, if with this particular transducer, I can get away with one preset to do all of my nerve scanning, all of my MSK scanning, and that as well. And the same thing with the curvilinear transducers. So you'll find that you can simplify things with just one preset often. So image optimization. First, we choose and act in a particular order. First, we decide, what do I want to look at? Well, I want to look at the median nerve at the wrist. I pick my transducer, which is going to be a high frequency linear transducer. We adjust the depth, adjust the focus, and adjust the gain if necessary. Now, the gain is not always necessarily needing to be adjusted, and in most transducers and machines now, you can get away without touching the gain and fiddling around too much. This is a good example of what not to do on the left. This is a marginally acceptable image, and this is a better image in a similar patient on the right side. Now, what we can see in the image on the left is that few things. One, we have this big black hole in the bottom, so we're missing a lot of screen real estate here that we can utilize. We are using a 12.5 megahertz transducer, which is acceptable, but in this particular machine, we also have access to a higher frequency transducer. The focal zone is down in the black abyss, which is really not that helpful. And we don't even have a label on this thing. On the right side, you can see that I've chosen a 18.5 megahertz transducer. The focal zone is in the middle of my target area. I've got a label on it, and the screen real estate is optimized. I didn't need to use any zoom here. I didn't have to adjust the gain. Okay, so back to transducer selection. As we've talked about before, high spatial resolution is optimized with higher frequency transducers. We have a lower penetration with these, and you're getting around 6 centimeters or so. We really enjoy the linear transducers because you also have a nice high temporal resolution as well. And when we're scanning, going back and forth to the nerves, we're using those higher frame rates to help us recognize structures as we scan back and forth. The curvy linear transducers are very helpful for for deeper structures, like the sciatic nerve in the proximal thigh, the tibial nerve and the popliteal fossa, depending on the individual. If you have someone who has a lot of adipose tissue, or they've had some surgery over the area, that the tissues are more attenuating and are requiring lower frequency ultrasound waves to penetrate. Just a little note here that the near field is called the Fresnel zone, and the far field is called a Fresnel zone. You can read about that in some of the sonology textbooks. I wanted to point out again about axial and lateral resolution, as Dr. Walker mentioned. So here's a picture. Axial resolution is the ability to differentiate between two different points in the vertical plane, whereas lateral resolution is within differentiating points in the horizontal plane. And the higher frequencies are able to improve both axial and lateral resolution. So the ultrasound transducers that we're using in neuromuscular ultrasound are going to be somewhere between 12 and 22 megahertz, which is going to give you the pretty much everything that you need. Even some of the deeper muscles and nerves, you can use a trapezoidal imaging and expand your ultrasound beam with the linear transducers to get a little deeper. Although I've decided that it's still best to use like a mid-frequency curvy linear transducer for those imaging. Here's a picture of the sciatic nerve in the proximal thigh in someone who's pretty thin. You can see I've labeled it. I didn't put a side on it. Oh yeah, here it is, left side. I've measured it. We're at 0.6 centimeters squared. And this one is just after the conjoint tendon and the semimembranosus come off of the ischial tuberosity. Here's the semimembranosus aponeurosis, and here's the biceps coming off here. Okay, let's talk about attenuation and time gain compensation again. I'm going to harp on this a little bit because this is a great way to optimize some of the far field imaging that we have. So the time gain compensation, what happens with the ultrasound beams is that just like all waves, they don't propagate. The higher frequency waves do not propagate as far as the low frequency waves. So just like sound, the volume of higher frequencies dissipates quicker than the volume or the intensity of low frequency waves. Now, attenuation means that these waves are just not being reflected. And when waves are not being reflected, we don't have imaging input, which means that we have a darker image. So tissues that absorb or reflect the ultrasound beam then make the image darker the deeper we go. Now, the processing of the ultrasound machine does actually compensate for this in the background, and so the gray map is part of that compensation. And so what it does is it increases the intensity or increases the gain the deeper it goes, but you can also do it with these sliders. So the top of the image is like a volume slider on a mixer, and the further down you go, the louder or the brighter that you can make it. So you can, in the right side here, you can see that this slider here, if I turn it to the slider to the right, then I'm going to make this section of the upper portion of the image brighter. And the same thing with this lowest slider. If I move it to the right, it's going to increase the brightness of the deep portion. So now let's talk about depth, focus, and gain. We're going to go back to this picture here that I mentioned before. So we can see here now that, as I've mentioned, we can improve this image partially by changing the transducer to a higher frequency. We can adjust the depth, we can adjust the focus, and get a more acceptable image. Now, you can get away with an image like this on the left side as well. But I'm just drawing your attention to the possibilities of making a better image. And whenever I'm teaching learners, I really enforce this, that getting a good image and learning how to hold and manipulate the transducer is most of the battle with learning ultrasound. So let's talk about holding the transducer. In most of the marketing images, you're going to see people holding transducers in the wrong way. So you see pictures of pretty people holding transducers in front of an ultrasound machine and smiling. They're going to be holding the transducer up on the top. Their hands are not going to be touching the patient or client, and there's really going to be no ultrasound gel. And I can tell you that the best thing you can do for your scanning is to use lots of ultrasound gel. And then, aside from using lots of gel and not being afraid to use gel, it's holding the transducer correctly. So the easiest way to describe how to hold a transducer is you want to grip the transducer lightly, and you need to place your ulnar aspect of your hand, so your fourth and fifth digits, on the skin of the limb that you're scanning, so that you can use these fingers as a brace to help lift the transducer off the skin. You need to stabilize the transducer, because if there's a vein just deep to the transducer and you're smushing it, you're going to miss it. And we use our hand to lift the transducer up and down, and then toggle it, wag it, heel and toe it, spin it around, and that's how you get a good picture. The probe handling with light pressure is very important as well. One of the mistakes that learners make in general is to forget about where their hand is and just crush the ultrasound transducer onto the patient. Most people can tolerate it well, but you're going to run into trouble with your superficial imaging and looking at small nerve fascicles if you do get into that habit. The other thing that bracing your hand against the skin does is it helps you to do fine manipulations with the transducer, and this minimizes artifacts of anisotropy. So when we're scanning, we want to dynamically adjust the depth, gain, frequency, and focus, and you'll see this during the scanning sessions where the probe is being constantly moved to optimize the image for the target. So a few of the other real core principles of neuromuscular ultrasound and ultrasound in general is that you really have to know your own limitations. Err on the side of caution and look for the clinical correlations that you would be expecting. So when we're starting, know what you know and know what you don't know. Don't overcall a diagnosis, and ask for help when you need it. It's very important that we consider the neuromuscular ultrasound as an assistant or a complement to the clinical examination and the electrodiagnostic evaluation. Just like MRI would be, or CT would be helpful in clinical correlation, and that so is neuromuscular ultrasound. We don't really use protocols for neuromuscular ultrasound, although we have some suggestions of it. We need to tailor the scanning to each patient itself. We have to consider our artifacts, anomalies, and the limitations of the ultrasound machine itself when we're scanning as well. Okay, so back to the technique. Sometimes we do have to change the transducers during a scanning session. For most nerves, we can stick with the linear transducer and for the entire scan. So you can look at the median nerve through its entire length with the same transducer with a few adjustments of the image if needed. Be consistent with your labeling. There are ways that you can label left and right, but at the bare minimum, label left and right for each of your images. We want to save images and video in both the short and the long axis. And when we're orienting our transducer, left by standard is cephalad or cranial. We can use zoom for deep targets and take lots of pictures and video. Of course, practice, 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 because this takes a long time to learn. Okay, let's talk about planes. In the bottom right-hand corner, we can see that this is the anatomical coronal plane, sagittal plane, and axial or horizontal plane. This is an ulnar nerve schwannoma with a 3D cuts here. So in the top left-hand, we can see that this is an axial image of the forearm. We have a transverse or a short axis view of the schwannoma. To the right here, we can see this is a sagittal view of the forearm, and it's a longitudinal or long axis view of the ulnar nerve and the associated schwannoma. This is a coronal view. Now, this coronal view was taken, is a digital reconstruction of the axial scanning. So let's dive into this a little bit more. The terms axial, sagittal, and corona are descriptions of the anatomic plane. So the top left here, this is an axial view. Whoops, I gotta go back. There we go. This is an axial view of the forearm, and we are short axis to the nerve itself. Short and long axis describe the target. Now, in this picture here, we can see that both the forearm and the target are in the same anatomic plane, but that's not always the case. We can see a situation where they're in different planes when we look at the supinator and the posterior interosseous nerve. And this video is not working for me. So I'm going to see if I can escape my... Okay. So here we can see that the posterior interosseous nerve is in short axis, and that the supinator itself is in long axis. So the fibers of the muscle are going from left to right, and whereas the posterior interosseous nerve is coming at us. So in this, we are in the axial view of the forearm. We are short axis to our target, which in this case would be the posterior interosseous nerve, and we're long axis to the supinator muscle itself. Okay, appearance of tissues. This image is of a nerve in the forearm, and this is the same sciatic nerve in the proximal thigh, as I've mentioned before. So let's look at some of the labels here. So in the very superficial portion of the screen, we have skin, then we have fat. These hyperechoic reflectors here are fibroadipose septa within the fat, not to be confused with the fascia, which is a thicker portion of the connective tissue here. This sciatic nerve is in the typical honeycomb description of the nerve itself. So you'll see labeling of nerves and descriptions of nerves in textbooks as the honeycomb. And not all nerves are in the honeycomb shape. So the sciatic nerve, proximally the tibial nerve before the tarsal tunnel, the median nerve at the wrist and forearm, you certainly can see the honeycomb shape of the nerve itself, but not all nerves are like that. Well, I'll come back to that in a second. Tendon, very densely arranged. Fat's hypoechoic and loosely arranged, and muscle has these loosely arranged fascicles, which are more hypoechoic than the surrounding tissue. So here's some descriptors. As I've said, tendon are densely packed. They're intercalated, and so they're slightly discontinuous with very high anisotropy. So when you wag your transducer, this will go from black to white very quickly, and that's how you identify tendons. So small movement of the transducer has large and significant changes in the echo intensity of tendon, which is less so than muscle, nerve, fat, and skin. The hyperechoic surrounding of the nerve here is the connective tissue, which is the epineurium. And then the hyperechoic portion or surrounding these fascicles is going to be the inner epineurium. And then what we can't really see is the perineurium itself. The nerve fascicle is hypoechoic and sometimes anechoic, which means that there's no reflection and it's perfectly black. And we can follow these fascicles individually. So these fascicles are continuous, whereas fascicles in muscle and tendon are discontinuous. Nerve fascicles are continuous, and you can trust it. You can follow a fascicle, say of the palmar cutaneous branch of the median nerve, through the forearm, and then watch it come off into the palm itself. So perfectly continuous. Now, bone, as Dr. Walker mentioned, there is perfect reflections off of bone. So bone is a perfect reflector. We can't see into it. We can only see the initial reflection. So here we have bone, and then we have posterior acoustic shadowing. So this is an artifact, but it's a helpful artifact because it tells us that this is bone. If it's perfectly black deep to it, it tells us that, well, this is a strong reflector. All the ultrasound waves are being reflected back, and we're seeing nothing deep to it. This is a C7 nerve root right here. This is the C6 becoming the upper trunk. And I wanted to use this picture to give you an idea that not all nerves are honeycomb-like. Here we can see that we have this moderately large anechoic structure, which is typical of the nerve roots. This is C7 here, and you can see that is definitely not like a honeycomb. Lastly, I want to talk about veins and arteries. These guys are easy. So veins, they can compress. Arteries do not. Here we have a vein without compression. In this image, the same vein is just compressed, and the artery is not. Arteries have some thicker walls, and you can see the reflections of these walls. Even without Doppler imaging, you can generally identify veins and arteries. Okay, I am going to stop there, and we'll have some questions.
Thank you, Peter. Very interesting talk. I loved it. There was a question about, can we further use M-mode for tissue characterization, pattern study, as in lung or detecting pneumothorax?
Yeah, so the M-mode you can use for some of the lung imaging. That is not my area of expertise. You're going to be using M-mode for lung movement itself.
And another question, what's the dynamic range and how to choose the appropriate range?
So the dynamic range is interesting. You really have to, there's no specific correct answer for what is the dynamic range. You have to really just play with your machine itself, and each machine is going to be different in terms of dynamic range. In general, the higher the dynamic range, the slower your frame rate is going to be, and you can adjust that by decreasing the persistence itself. But going into detail about about each of those aspects of is beyond the limits of this talk. We'd have to sit down with the machine and look at that.
Because there was a question about what's persistence and how to adjust it.
Yeah, that's beyond the basics. Yeah.
And another question, should I turn on tissue harmonic imaging constantly in every exam?
Harmonic imaging. Yeah, so I pretty much use harmonic imaging for most of them. I guess it really just depends on the machine that you're using as well. So the harmonic imaging can be very helpful, but in some machines, the harmonic imaging just makes it painfully slow to do dynamic scanning.
Okay, that's excellent. I don't think we have any more questions. Thanks so much. It was very interesting talk. And I believe all that the feedback is coming excellent. And thanks so much.
No problem. Thank you.
Thank you. So now to media conference, please.
Yeah, thank you all. I'm Iman. So we now have, thank you, dear Dr. Peter and Dr. Francis, for the interesting talks, and thanks, Dr. Yasser, for moderating the session. And now we shall have a short break for 20 minutes, and we shall get back at 4 p.m. Cairo time to complete the program. We have about 3 talks and after the break. So we shall have a short break now. So see you after 20 minutes. Thank you. You can stay in the webinar actually. So we have some ads, or like we have an announcement for an upcoming course as well at the end of this month. So stay tuned to the end. Thank you.
There's a couple of questions that are coming through here. Is it okay if I?
Yeah, sure.
Okay. Yeah. So there's a question about recommended textbooks. Yeah, there's a couple of textbooks. Probably, I know that Preston and Shapiro just released their 4th edition of electrodiagnostic medicine. There's ultrasound correlates now in that 4th edition. So, there weren't many changes between 2nd and 3rd editions, but the 4th one does have some quite a bit of ultrasound in it, and Dave put a lot of effort into that. So from an ultrasound correlate perspective, I would go with that. Jeff Strakowski's Introduction to Ultrasound would be another one that I would strongly recommend as well. And then Francis's book that he did with Mike Cartwright is a good intro as well. If you're really, really, really looking at the details of physics, then there are some other detailed sonography books, but I think it's a bit over the top for what we need. There's another question about, is 10 to 12 megahertz acceptable for most nerves? Yeah, I don't think so. I think you really want, if your transducer is a 1210 or a 12.9, you're really going to want something a little higher than that, because the utility of ultrasound in the EMG lab especially is going to be looking at some of these smaller nerves and superficial nerves, and you're going to need 15 or higher. Needle visualization is very useful, but certainly I use ultrasound to guide the EMG needle in difficult cases. So if there's some change in anatomy, if they're larger, or if I'm just struggling with someone, I'll break out the ultrasound, find the muscle, and then hit it. And the EMG needles are around 26 gauge. They're pretty easy to see, and it's very safe to practice your needle visualization in the EMG lab. There's a question about adjusting focus. you're aiming at your target, which is really going to be in the middle of the screen. So again, it's the adjustment is close to what you're looking for. So if you're looking at the musculocutaneous nerve in the arm, then you want to make sure that your focus is close to the musculocutaneous nerve, if your machine has a focus at all. Some of the newer machines do not have any focus adjustment. They just have a general scanning area.
Okay. Thanks,
Yeah,
Peter.
thank you.
Yeah. Go on, Iman. Yeah.
No, I think we have answered all the questions, I guess. So I don't see any more questions for this session. So thank you, Dr. Peter.
Oh, yeah.
Thank
There's
you.
one question here in the Q&A about,
Really?
that's the sphincter. Oh yeah. Is there a specific probe for sphincter muscles? I guess it depends on what your approach is. The pelvic floor ultrasound is going to be generally curvilinear transducers if you are coming at it from a muscle movement or incontinence perspective. If you are looking at the superficial structures, then it's going to be a linear transducer. But predominantly, you're looking at curvilinear transducers for if you are scanning. I'll type in the answer for the recommended books in a second.
Well, thanks, Peter. I don't know. I think we answered all the questions. Don't think there's any more.
Thank you.
Yeah, I guess so.
Yeah.
Yeah, thank you, Dr. Peter. So we'll just come back at 4 p.m. to continue the program. Thank you all. Just have a cup of coffee and take a break. Thank you.
뭐 청진기라든지 저희가 지금 해진을 돌 때 뭐 청진기라든지 아니면은 진찰만으로 되게 이제 환자의 상태를 파악을 하는데 이제 그 정도로는 환자의 상태 변화를 파악하는데 좀 한계가 있습니다.
이 기계는 간단하고 간편한 기계지만 그 응급 현장에서 그 전송이 빨리 될 수 있었고 화질도 선명하고 로딩 속도도 빠른 편이어서 정확한 진단
Well, welcome everybody. Back to the second half of today's, and I have the pleasure to introduce my colleague, Professor Iman Tawfiq. She's associate professor in our department, Physical Medicine, Rheumatology, and Rehabilitation in Shams University. Iman received her training in neuromuscular ultrasonography in USA starting from 2003. She completed her neuromuscular ultrasonography fellowship in the neurology department, Wake Forest School of Medicine, United States in 2014, under supervision of Professor Francis Walker and Dr. Michael Cartwright. Since then, she continued to develop her skills in neuromuscular ultrasonography, and she started and organized the first neuromuscular ultrasound hands-on workshop in Egypt and the Middle East. Later on, in 2018, she founded the Egyptian Neuromuscular Ultrasound Society in collaboration with the Egyptian Society of Electrodiagnosis Medicine. And 2020, she co-founded the African Society of Musculoskeletal and Neuromuscular Ultrasonography. She has extensive publication history in neuromuscular ultrasound field and recently shared in publishing a chapter in neuromuscular ultrasound in pediatrics. May I now welcome Professor Dr. Iman. She will speak to us about sonoanatomy of basic upper limb nerves. Dr. Iman? There's a problem with sound. We cannot hear you.
Okay, can you hear me now?
Yeah, yeah.
Okay, is everything fine now? Can you hear me well?
Yes, we can hear you.
Okay, can you see the screen? So shall I start? Can you see the screen and hear me my voice or what?
We can see it.
Yeah.
Dr. Iman, we can see the screen and we can hear you very well.
Okay, thank you. So hi everyone. This talk will be about sonoanatomy of the basic upper limb nerves, and I thought it would be a good idea to start with this before you view the videos at the end of this day, because it will make it easier for you to follow the videos. First of all, I don't have any conflicts of interest to declare related to this talk or to the course. And I will focus just on the nerves of the basic nerves of the upper limb, including median, ulnar, and radial nerves. And I'll talk about 3 points: how to identify the nerves in ultrasound image. I will go through this very quickly because we have already Dr. Walker and Dr. Peter have talked about this. But I will focus on the anatomical course of each nerve and the sonoanatomy of each nerve at different levels. So we will see the cross-section anatomy and the corresponding axial view of the ultrasound of each nerve at different levels along the entire course. So as Dr. Walker had just explained to us, that we have to know the structure of the nerve to be able to understand how the nerve looks like in ultrasound image, because in ultrasound you're talking about anatomy, so we need to know the morphology. And as Dr. Peter mentioned, we see, and Dr. Walker mentioned as well, we see the nerve fascicle in ultrasound. We don't see the nerve fibers. So this is just a cross-section of the nerve showing the nerve fascicles and the interfascicular septum and the outer layer of the nerve, and this is just the nerve fiber. So in the axial view, we see this typical honeycomb structure, just the hypoechoic dots embedded in hyperechoic backgrounds. These hypoechoic dots represent the nerve fascicle, while these hyperechoic bands, separating the septum, separating the fascicles from each other. And the outer connective tissue layer of the nerve appears as a bold hyperechoic or echogenic line surrounding the nerve. If you look in longitudinal view, if you put your probe here, just to look at this view along the long axis of the nerve, you will see the nerve cable-like structure. Here is the median nerve at the level of the mid-forearm, running between the flexor torum superficialis and profundus. You can see it as a cable-like structure with hypoechoic bundles alternating with hyperechoic bands, representing again the nerve fascicles and the interfascicular septum. And this bold parallel echogenic line representing the outer connective tissue layer of the nerve. But you have to put in consideration that not all nerves have the same echogenic appearance, and the same nerve does not have the same appearance at all levels. The shape as well varies from one nerve to another and from one level to another. For example, here is the median and ulnar nerve at the level of the mid-forearm, acquiring the typical honeycomb structure, as Dr. Peter has just shown us. But actually, for the radial nerve, especially at the level along the level of the arm, it looks like one bundle, one hypoechoic bundle or trunk. And this is normal for the radial nerve, so don't consider this as a pathological finding. So you have to know the normal appearance of each nerve at each level. The same apply, the same nerve does not have the same appearance at all levels. For example, this is the ulnar nerve at the level of the mid-forearm running between the flexor carpi ulnaris and the FTP, and this is the ulnar nerve just distal to the cubital tunnel. And you can see this typical honeycomb appearance again. But at the ulnar groove, the nerve normally looks hypoechoic like this. So this is totally normal for the ulnar nerve at the ulnar groove level, and don't consider that pathological unless it is associated with other findings, especially increased cross-sectional area. The same applies for the median nerve. The median nerve at the level of the mid-forearm typically acquire the honeycomb calibriform or reticular pattern, but at the palm, if you scan or trace the nerve distally distal the carpal tunnel and see it in the palm, it's totally hypoechoic. And this actually related to the distribution and the angle of the fascicle and the relation of the angle of the probe with the fascicle. But this is totally normal for the median nerve at this level. So besides the echogenic property, the peripheral nerves have other features as well. It is relatively immobile compared to the tendons, which are highly mobile. It is less affected by anisotropy, as Dr. Walker have just explained to us. And in normal states, it does not show Doppler signal. So this is the mobility of the median nerve. Here is the median nerve flexor tendons. The flexor tendons is highly mobile. Median nerve just glides on top of the flexor tendons. So it does not have the same mobility as the tendons. And this is one of the methods that you use to differentiate between the nerve and the tendon. And it is less affected by anisotropy. So the anisotropy is a feature of the tendon. So this is a biceps tendon occipital groove with the angle perpendicular to the tendon, and this is the inclination of the probe. It turns hypoechoic. The nerve does not have this feature to the same extent as the tendons. And there's no Doppler signal if you put your Doppler on the nerve, but you may see very small nutrient vessels. But there should be no perineural or intraneural signal. Just I'm getting back, sorry. So we identify the nerves. How do we identify the nerves? To identify the nerve in ultrasound image by the echogenic property that we have just explained, and we have to differentiate the nerve from other structures, but we depend mainly on the anatomical landmarks that we use to identify the nerve. For example, associating blood vascular structure. For example, the nerve is passing between two muscle layers. So from knowing the anatomy, we use this landmark as a sign in the street that guide us to the road. So to differentiate nerves from tendons, as we just said, we can just assess the mobility or actively ask the patient to actively contract the tendon or the muscle. So you see the movement in the tendon to differentiate between nerve and tendon. And for here, sometimes in the distal wrist crease, you can see the median nerve here and the flexor carpi radialis just outside the tunnel lateral to the nerve, and you can easily confuse between these two structures. You can differentiate by active movement or passive movement and see the movement in this tendon, or you can just incline your probe to create anisotropy and to see the change in the echogenic property. You can as well trace back these structures. You will find that then the tendon will turn and expand into muscle while the nerve will remain as a nerve as you go proximally. Differentiating nerve from blood vessel is very easy. The blood vessel or the artery or the vein is anechoic, completely anechoic. The artery is pulsating, the vein is compressible by pressure and expanded by release of the pressure. And of course, the nerve acquires the typical honeycomb structure, and you can put your Doppler to see the signal. So the most important is anatomical landmarks. I will not take a lot of time for this because you will see that in the cross-sectional anatomy, the next sections, and you will see that in the tracing videos as well at the end of the day. It's just, for example, we identify the median nerve by its position as a cubital fossa besides medial to the brachial artery. And we use the ulnar artery to identify the ulnar nerve, for example, at the level of the mid-forearm. So these are just landmarks that you are going to see in the next slides. So we shall start with the median nerve. And as you know all, that the median nerve arises from the brachial plexus by a median and lateral root with the root value extending from C5 to C1. And then after it descends from the infraclavicular region to the axilla, it is located superior lateral or superior to the axillary artery and vein. And it keeps this lateral relation with the artery until the level of the mid-arm or the level of the insertion of coracobrachialis, where the median nerve crosses in front of the artery to run along its medial side down to the cubital fossa. And in the cubital fossa, the median nerve is located just adjacent and medial to the brachial artery, and both of them are located just medial to the biceps tendon, and all of them run on top of a large broad muscle, which is the brachialis muscle. And don't forget that the medial boundary of the cubital fossa is the pronator teres, and the lateral boundary is the brachioradialis with the radial nerve running between it and the brachialis muscle. After that, the nerve leaves the cubital fossa and enters the forearm, passing between the two heads of pronator teres, which is the possible site of entrapment, and then it descends along the midline of the forearm. Running between two muscle layers. The superficial is the flexor digitorum superficialis, and deep are the flexor pollicis longus and the flexor digitorum profundus. Then it descends along the distal third of the forearm, crossing in front of the pronator quadratus, a quadrilateral muscle here, and it will then enter the carpal tunnel with the tendons, as you know, covered by the flexor retinaculum to divide into terminal branches. This is the carpal tunnel at the level of the palm. So as regard the branch, we're not going in the basic course to study the branch because the scanning and tracing of branches of the important branch are topic of the intermediate course, not the basic level. So just this in image, just a reminder for the branches of the median nerve. So this is the surface anatomy of the median nerve. So if you imagine the surface anatomy, you can imagine the surface anatomy of the median nerve extending from the medial axilla here, following the brachial artery, the proximal portion of the brachial artery, the axillary artery right here, and then it will descend just medial to the brachial artery and along the midline of the forearm. So knowing this surface anatomy is important because it actually represents that your tracing path that you are going to trace the nerve along. Not the surface. The surface anatomy is not just important, but equally important as well is the cross-sectional anatomy, because the axial view corresponds to the the corresponding cross-section. For example, if you put your probe at the midline, this is a cross-section at the level of the mid-forearm. If you put your probe on the palmar aspect of the mid-forearm, you will see the structures in the midline. You will see the median nerve running between two muscle layers, flexor digitorum superficialis here, and deep is flexor pollicis longus and flexor digitorum profundus. With this portion of muscle belly representing here, right here in this image, representing here the flexor carpi radialis and its tendon. If you slide your probe on the medial side, you will see the structures at the medial side, represented by the ulnar artery here. This radial structure adjacent and medial to the artery, the ulnar nerve, and running between two muscle layers, the flexor carpi annalis here on the top, and the medial portion of the flexor digitorum profundus. And you can see here as well a portion of the flexor digitorum superficialis right here in the corresponding ultrasound image. So it's really important to know the cross-section anatomy to identify your landmarks. So what we are going to do in the next slide for the median nerve is to see the cross-sectional anatomy and the corresponding axial view, ultrasound axial view at the levels of axilla, mid-arm, cubital fossa, pronator teres, mid-forearm, distal forearm, and carpal tunnel. If we start at the level of the axilla, the landmark that you are commonly used to identify the distribution of the nerves around is the axillary artery, and this is the axillary vein. And you can see here this structure. This is the median nerve located superior lateral to the axillary, or sometimes you see it lateral, or sometimes you see it superior, but here is superior lateral. And you can see on the lateral side the biceps coracobrachialis with the musculocutaneous nerve in between. So here in the image, this is just the lateral side of the image, this is the medial side. Here in the ultrasound image, it is the lateral side, and this is the medial side. You can see the axillary artery in the center, and you can see this nerve, the median nerve located superior lateral to the artery. And you can see here two muscle, biceps and coracobrachialis. But remember, there are wide anatomical variations as regards the distribution of the peripheral nerves at the level of the axilla, and is usually represented in the articles by this image or this chart, representing the possible locations of the main nerves of the upper limb, median, ulnar, radial, and as well musculocutaneous around the axillary artery based on anatomical or cadaver study. So if you imagine this chart or pie chart with this center is represented by the axillary artery, and the chart is divided into 12 triangles or 12 sections. The locations of the median nerve, the possible location of the median nerve you can find is in areas or sectors 10, 11, and 12. So you may see it just lateral to the artery, superior lateral, or even superior. Same for the ulnar. It's located on the medial side of the axillary artery. You can find it here in sectors 1, 2, 3, 4. So you may see it superior medial, medial, inferior medial. As for the radial artery, you can localize the nerve posterior to the axillary artery in sections or sectors 5, 6, and 7. And same here for the musculocutaneous nerve. So you have to put this in mind. And that's why we don't start the tracing of the nerve at the level of the axilla because of its wide anatomical variation. We prefer to start from a distal level and go up to the axilla. If you go further distal, you will see the median nerve crossing in front of the brachial artery. So this is the previous image of the nerve located superior lateral to the axillary artery. And you can see the median nerve here. Instead of its lateral position here, it starts to cross in front of the brachial artery right here. As it reaches the cubital fossa, this is a diagram showing the relations and the contents of the cubital fossa. You can see the brachial artery, and you can see the median nerve lies just adjacent and medial to the brachial artery. And both are covered by the bicipital aponeurosis, and both lie on the medial side of the biceps tendon. And you can see a vein here in the subcutaneous tissue, the antecubital vein or the basilic vein, all running in front of the brachialis muscle, here the broad large muscle. And don't forget that the medial boundary of the cubital fossa is represented by the pronator teres, and the lateral boundary is represented by the brachioradialis. Here is the cross-section view at the level of the cubital fossa. Here our landmark, the brachial artery. You can see the median nerve adjacent and just medial to it. And this is the basilic vein. And you can see this large muscle is the brachialis muscle. And the underlying bone is the humerus. And this is the medial boundary of the cubital fossa represented by the pronator teres. If you see the corresponding axial image, ultrasound axial image, you will see here the brachial artery, our anatomical landmark. And here is the median nerve. The median nerve just located medial and adjacent to the brachial artery, and both running on top of the brachialis muscle. And you can see here part of the biceps tendon here. So both these structures lie on the medial side of the biceps tendon. And you can see another muscle on the medial side. This is the pronator teres muscle. And you can see here, down here, the bone profile of the trochlea and the capitellum of the humerus with the articular cartilage in between. If you go further distal, you will see the median nerve running between the two heads of pronator teres. This large head is the humeral head, and this small slip of the muscle is the ulnar head of the pronator teres. Sometimes it's not absent in some individuals, okay? And you can see that the nerve turns oblong or relatively flat compared to the other level. And this is, again, normal shape of the median nerve at this level. You usually see the ulnar artery crossing here underneath the median nerve between it and the muscle. And you can see here the longitudinal view of the median nerve running between the two heads of pronator teres. There is a real anatomical variation where you can see the median nerve running actually inside and perforate the humeral head. And I have just seen this in 2 of my patients where the nerve just perforates the humeral head of the pronator teres. If you go further distal, we reach the level of the mid-forearm. So if you see this section, you will see here the midline median nerve without any vascular structure accompanying it, except of course if there is persistent median artery. You can see here is median nerve just running between 2 muscle layers, superficially the flexor tutorum superficialis, and deep on the lateral aspect the flexor pollicis longus, and next to it is the lateral portion of the flexor tutorum profundus, and this muscle belly represents the flexor carpi radialis, and this is part of its tendon starting to form right here. As we go distal and approach the distal third of the forearm, you will see another muscle appearing at the bottom of the image. This is the pronator quadrilateral muscle. This is the pronator quadratus with its fibers running from the medius to the ulna. And you can see the median nerve running, crossing over the muscle and actually rotating around the lateral edge of the flexor storm superficialis on its way to the carpal tunnel. And this is the corresponding cross-section. This is the ponietal quadratus median nerve on its way to the carpal tunnel. And this is just the muscle belly of the FDS, and this is just tendon starting to form inside the muscle. So how you can see now how the axial view corresponds typically to the cross-section. So if you know the cross-section anatomy well, you will be able to master the tracing in a better way. At the level of the carpal tunnel, you know that the median nerve runs under the flexor retinaculum or the transverse carpal ligament on top of the flexor tendon. On the lateral aspect, and that's the tendon, is the flexor pollicis longus tendon running in its own synovial sheath, and the other flexor tendons arranged in 2 rows. Outside the tunnel and on the lateral aspect, you can see the flexor carpia radialis tendon right here. Don't forget that the tunnel has an inlet and outlet, and the external landmark of the outlet is represented by the distal wrist crease. And if you go further distal, you will be at the outlet. So here is the diagrammatic representation of the carpal tunnel. Here is the median nerve running on top of the flexor tendons, and this is the flexor pollicis longus inside the tunnel in the lateral aspect, and this outside the tunnel is the flexor carpia radialis, and this is the transverse carpal ligament running just on top of the nerve. Just a zoomed picture. This is the flexor retinaculum, median nerve, flexor tendon. This is just lateral side. So you'll see here another tendon, flexor carpia radialis, and don't confuse it with the median nerve. If you are confused, just as we just said, just toggle your transducer, create anisotropy, ask the patient to actively contract the tendon or the muscle, or just to trace these structures back to identify them. If you go further distal at the level of the tunnel outlet, you will see the nerve goes a deeper level. And usually the flexor retinaculum is thicker and more straight at the level of the tunnel outlet. And the tunnel outlet is actually narrower than the inlet, and that's why the nerve gets entrapped at the outlet, causing increased cross-sectional area at the level of the inlet. But you have to put in mind as well that it's not a strict rule to find just enlargement of the cross-sectional area at the level of the inlet. You can find enlargement at any level across the tunnel, even at the level of the bottom. So just to keep that in mind. So I will go through the most common anatomical variants that you can see when you scan the median nerve. The most common variant we see is the nerve being bifid. So the bifid median nerve, where the nerve is split into 2 bundles. Sometimes it splits into one large lateral bundle and one smaller medial bundle with a fibrous band in between, or you can see as nearly equal bundles with no fibrous tissue, fibrous band in between. The bifid median nerve may be associated as well with persistent median artery or just persistent median artery. You can find persistent median artery and veins as well, but the nerve is not bifid. This is from an article by Dr. Walker. It's a really nice article here. So this is a picture of a bifid median nerve divided into 2 bundles at the level of the distal wrist crease. It is the lateral bundle. This is a smaller medial bundle and separated by a small fibrous band. Here is the same bifid median nerve, and here it splits only into 2. It splits into 2 equally, almost equal bundles with no fibrous band in between. The next anatomical variant, as you can see, the persistent median artery. The median artery should disappear in the intratunnel life. If it persists, it arises from the brachial artery at the level of the mid-forearm and join the median nerve right here. And you will see it as a small, rounded, pulsating structure here with the Doppler signal. So you have to put that in mind, so not to confuse it with one of the fascicles of the nerve, and don't include it in your measurement of the cross-sectional area. Here is the median nerve at the level of the distal is showing the persistent medial artery just adjacent to the nerve, but the nerve here is just one bundle. It's not bifid here. The third anatomical variant that you can see is accessory muscle, as Dr. Walker has explained to us, and you can see here an accessory triangular muscle inside the carpal tunnel intruding on the median nerve. It can be either flexor storm superficialis or lumbrical. You can know by the action. So if it retracts with flexion and appears with extension, then this is an accessory flexor storm superficialis. Sorry. So we come to the ulnar nerve. So the ulnar nerve arises from the medial cord of the brachial plexus, as you all know, and it has a straightforward surface anatomy. It just runs from the medial side of the axilla along the medial side of the arm and medial side of the forearm down to the guide canal. At the axilla, its relation, it is located medial to the axillary artery and vein, and sometimes, as we said, it may be situated just medial superior or medial inferior, or sometimes you can see it between the artery and vein. and it keeps its medial relation with the artery till the level of the distal arm or mid-arm, where it will penetrate the medial intermuscular septum to run on top of the triceps muscle on its way to the ulnar groove. And here the nerve just is covered by the medial intermuscular septum and is commonly associated with an artery called the superior ulnar collateral artery. Then the nerve will go just behind the medial epicondyle in the ulnar groove between the medial epicondyle and the cranium on its way to that cubital tunnel proper, or the true cubital tunnel, where it enters between the two heads of the flexor carpi ulnaris on its way to the medial side of the forearm. So at the medial side of the forearm, it is located between two muscles, superficially the flexor carpi ulnaris and deep in the ulnar portion of the flexor sternum profundus. And at the distal half of the forearm, it's associated with the ulnar artery. So the ulnar artery approaches the ulnar nerve at the level of the mid forearm or somewhat behind, proximal or distal. So we commonly use the ulnar artery as our landmark to identify the ulnar nerve along the distal portion of the forearm. Then the nerve goes down to the Guy's canal, passing just lateral to the pisiform bone, accompanied by the ulnar artery as well. And then it will divide at the level of the hamate into a deep motor ulnar and superficial sensory ulnar nerves. So the cross-sectional anatomy and the tracing path of the nerve is straightforward. So it's really easy nerve to trace. And we are going to see the cross-sectional at the level of the cross-sectional anatomy and the corresponding ultrasound image at the level of the axilla, mid-arm, ulnar groove, cubital tunnel proper, mid-forearm, and Guy's canal. So if you start here at the level of the axilla, you will see the same image as we have just seen for the median nerve. This is the axillary artery, this is the axillary vein, this is the median nerve that we have just seen, and this is the ulnar artery just medial to the axillary artery and vein. Sometimes you can see it here between the artery and vein. And here is a corresponding image, ultrasound image. This is medial, this is lateral, so you see the ulnar nerve just medial to the axillary artery and vein, and this is just a slight compression, so the nerve is not completely expanded here. The vein, sorry, not completely expanded here. Just don't forget this map when you scan the axilla and keep in mind the anatomical variations. At the level above the elbow, at the level of the mid-arm, you will see the nerve running on top of the triceps muscle, accompanied by a small artery called the superior ulnar collateral artery. And it is just here, if you can see this, it's just covered by the medial intermuscular septum, this hyperechoic band here. So this is the ulnar nerve running on top of the triceps, and this is, of course, the profile of the humerus. This is a cross-section that we are taking, just the ulnar nerve running on top under the medial intermuscular septum on top of the triceps muscle. As you go to the ulnar groove, you will see the nerve in the ulnar groove between just behind the medial epicondyle. And sometimes it's associated as well with a small artery called the posterior recurrent ulnar artery. If manipulated probe, you can get the image of aspiral ligament extending between medial epicondyle and the cranium, but it's not evident here. And you can see that the ulnar nerve looks extremely hyperechoic, but it is within average cross-sectional area. So again, this is normal appearance of the ulnar nerve at this level. This is a probe position. To get the nerve at this level, you have to span your probe between the medial epicondyle and olecranon. If you go further, distal to the elbow, you will see the nerve running between the two heads of the flexor carpi ulnaris, ulnar head and the radial head. And you can see here, it's kidney-like a kidney-shaped or like oval, more oval structure. Here is the typical honeycomb appearance of the ulnar nerve running between the two heads of the flexor carpi ulnaris. And it's commonly associated with the same artery as in ulnar groove, the posterior recurrent ulnar artery. And you can see here a band, a white band connecting the two heads of the flexor carpi ulnaris. It is the arcuate ligament. This is a cross-sectional view. You can see here these two muscles, two heads of the flexor carpi ulnaris with the ulnar nerve running just between. This level is called the cubital tunnel proper, or the true cubital tunnel. This is just the arcuate ligament connecting the two heads. This is just another image of the ulnar nerve running between the two heads of the FCU. If you go further distal, you will see the first image that you have seen earlier in the slides. You will see here the ulnar artery. So here is the ulnar artery. You can see adjacent to it this yellow structure. This is the ulnar nerve. And you can see two muscles here. The superficial one is the flexor carpi ulnaris. Deep one is the ulnar portion of the flexor sternum profundus. And you can see here part of the flexor sternum superficialis right here. As we approach the Guy's canal, this is the Guy's canal forming the lateral boundary of the pisiform bone, and it is occupied by the ulnar artery and the ulnar nerve just adjacent and medial to the ulnar artery, and the floor is formed by the transverse carpal ligament. So this is the pisiform bone, the bone profile. It's sharp, convex, hyperechoic bone with an ulnar artery. So we use the ulnar artery as our landmark to identify the nerve just medial and adjacent to the artery. But actually the Gyn canal is composed of three zones, not one zone. So it's composed of zone 1, zone 2, and zone 3. Zone 1 is the main zone, or the Gyn canal proper. And it's located at the level of the pisiform bone and occupied by the main trunk of the ulnar nerve. While zone 2 and 3 are located just distal to the pisiform bone at the level of the hamate. And the lateral one, the lateral zone here in red, is the zone 2 and is occupied by the motor branch of the ulnar nerve. While this blue zone, zone 3, is occupied by the sensory branch of the ulnar nerve. You can see here zone 1 with the at the level of the pisiform bone. Just it is the main trunk of the ulnar nerve, and this is the ulnar artery. If you see this image on top, you will see that it divides into two hypoechoic branches. This is equal to zone 2 and zone 3, zone 2 lateral and zone 3 medial here. So these are at the level of the hamate distal to the pisiform bone. These are zones 2 and 3 for the ulnar nerve occupied by the branches of the ulnar nerve. As for anatomical variants that we commonly see with ulnar nerve tracing or scanning, is abnormal mobility of the ulnar nerve at the level of the ulnar groove. So normally the ulnar nerve, the yellow here one, runs just behind the medial epicondyle. And in with flexion of the elbow, it should remain behind the medial epicondyle, or it just may move medially for a few millimeters. But if it jumps in front or on top of the medial epicondyle, this is called the ulnar nerve subluxation. And if it jumps anterior to the not top, but anterior to the medial epicondyle, it's called ulnar nerve dislocation. And sometimes this is associated with medial displacement of the triceps muscle as well, which is known as the triceps snapping. This is the ulnar nerve behind the medial epicondyle with extension of the elbow, and this is with flexion. You can see the ulnar nerve jumps on top of the medial epicondyle. It is just another nerve in case of ulnar nerve entrapment, and the nerve was extremely enlarged here, and with flexion of the elbow, it does not remain behind the epicondyle, but just run on top of it. Here is a complete dislocation. This is medial epicondyle, this is anterior, this is posterior. It should remain here with flexion of the elbow. It just jumps here in front of the medial epicondyle. And you can see this in this video. Here is the ulnar nerve, and as the patient flexes the elbow, you will see the ulnar nerve jumps here, right here in front of the condyle. So this is a picture showing the medial triceps, the snapping of the medial head of the triceps, in which the medial head medially displaces and runs behind the ulnar nerve on top of the medial epicondyle. Another anomaly or anatomical variant that you can see a triangular muscle here at the ulnar groove on top of the ulnar nerve. This is accessory anconeus muscle. Of course, sometimes there is a distal that has the same appearance of a triceps muscle. So sometimes the triceps muscle extends distally. So you are not sure if this is accessory anconeus or triceps. You can just simply differentiate by tracing back this muscle. If it's continuous with the triceps, so it is a part of the triceps. If it's not continuous, then it is an accessory anconeus. You can see as well accessory abductor digiti minimi at the level of the Gyn canal on top of the ulnar nerve here. So you can see that this is not really a variation. I have seen this in several patients. So we come to the last nerve here, the radial nerve. And the radial nerve arises from the posterior cord of the brachial plexus, and it keeps a posterior relation with the axillary artery and vein. So it runs posterior or behind the axillary artery and vein. And then it has a curved course. It curves around the humerus on its way to the cubital fossa. And at the level of the distal third of the arm, it penetrates the lateral intermuscular septum to run toward the lateral cubital fossa, to become superficial and run toward the lateral cubital fossa. So here is the lateral cubital fossa with the radial nerve running just on the lateral side and starts to divide into two terminal branches, the deep branch and superficial branch. Here is the radial nerve, the main trunk of the radial nerve, and you can see a branch here This is the deep radial nerve, which will turn into posterior interosseous nerve running between the two heads of the supinator muscle. And you can see here the superficial radial will continue its pathway toward the radial wrist along the radial aspect of along the radial edge of the forearm. This is superficial radial nerve running along the radial edge of the forearm, and it runs closely associated with the radial artery at the distal third of the forearm right here. So just I'm looking for the time, so not to override over the next talk. This is the radial nerve at the level of the axilla. Back to this image, we can see at the center the axillary artery, the axillary vein. Here is the medial nerve that we have just seen, the ulnar nerve, and the radial nerve here located posterior. So you can see it posterior, posterior inferior, or you can just see it posterior medial or posterior lateral, as we have seen in the chart. This is the axillary artery, and this is the radial nerve. And here it actually acquired the typical honeycomb structure, just on its just posterior and just on the medial side of the axillary artery. Here is another image of the radial nerve on its level of the axilla running toward the axillary artery, and here it looks like a train of fascicles. And it's really common to see the nerve here like a train of fascicles here. You cannot see it as a rounded or oval structure. You will see that in the video at the end of the day. Again, don't remember this chart or this pie chart. Here, the radial nerve at the level of the spiral groove, it just runs very close to the humerus and is covered by the triceps muscle and is commonly associated with the deep radial artery or profunda brachii artery. So you can here see the radial nerve just running close to the humerus, just on top of the humerus here. This is the radial nerve appearing as one bundle, and this is the artery associated with it. This is at the level of the spiral groove, and this is the proposition for scanning at this level. More distal, you will see the radial nerve running alone without any vascular structure on its way to the lateral cubital fossa, to the bone profile of the humerus. At the level of the elbow, you will see here the radial nerve. The radial nerve runs in the fascial plane between the brachioradialis laterally and the brachialis muscle medially. So you can see here the radial nerve running in this fascial plane. You will not see the radial nerve as one trunk. You will see it as two hypoechoic structures here, representing the deep radial branch and the superficial radial branch here. This is what we call snake eyes or frog eyes appearance, just to remember the appearance of the nerve at this level. This is the level of the lateral cubital fossa, and here is the humeral capitula right here. This is the brachialis, and this is brachioradialis laterally. So following the nerve, the branches of the radial nerve. To follow the radial nerve, you have to follow the deep radial branch, you have to follow the nerve from the lateral cubital fossa and go to the extensor compartment. So you have to see the nerve between the two heads of supinator. And to do that, you may need to pronate the forearm to be able to do that. This is just the deep radial nerve at just one small rounded fascicle running under the arcade of Rosse here, just before it enters the supinator muscle. And this is a mobile wad representing the extensor carpi radialis longus and brevis. So as we go further distal and follow the deep radial nerve, it now becomes a posterior interosseous nerve and running between these two hypoechoic muscle belly, the superficial head of supinator and the deep head of the supinator. And on top, you can see part of the mobile wad and the extensor digitorum as well. This is just this tiny flat nerve. This is the posterior interosseous nerve. And sometimes you can see a few fascicles running behind each other as a train of fascicle 2 or 3 fascicles. Or sometimes you see it as one fascicle like here. As regards posterior interosseous, there's just one interesting variation that has been reported in Muscle and Nerve in 2016, where the nerve runs not between the two heads of supinator, but runs on top of the supinator. And it's actually believed that this variant may be protective against the compression of the ulnar nerve between the two heads. So this was an interesting article. If you follow the other branch of the radial nerve, the superficial nerve, medial nerve at the elbow, we have to start at the level of the elbow again. See the nerve as two hypoechoic structure running between the brachioradialis laterally and the brachialis medially. And if you follow the nerve further distal, you will see this tiny hypoechoic rounded structure, oval structure approaching the radial artery and running underneath the brachioradialis. This is superficial radial nerve. You can see here, although the superficial radial nerve is considered a tiny nerve, but it's actually very easy to trace. And in certain levels, it acquired, also this small, it's acquired the typical honeycomb structure. Here at the level of the mid forearm, approaching the radial artery, and it looks like flat nerve here. just the brachioradialis on top of the nerve, and this is, of course, the bone profile of the radius. You can follow actually the nerve the further distal till it jumps. Here it jumps over the radius on its way to the first extensor compartment, and here it jumps over the first extensor compartment. So you can trace the nerve, and if you have a close look, you will see that the nerve will start to divide into 2 terminal branches, sometimes into 3, and you will see that in the tracing video at the end of the day. So I think we come to the end of the talk by scanning the superficial radial nerve, and I hope it's beneficial. Thank you for your time. Thank you.
Thank you, Professor Iman. That was very interesting talk. I believe all the feedback has been very good, actually. We have some questions. One, can palmaris longus muscle cause carpal tunnel as an anatomical variation?
Yeah, it's not common to see, but I have seen it in 2 of my patients where the palmaris, you can see a variation in the palmaris longus at the level of the tunnel, where you commonly see the tendon, you don't see the muscle. Sometimes there is a reversed palmaris longus where there is a muscle belly. There is actually the palmaris longus is the muscle most commonly associated with anatomical variation. It may absent, may be just tendinous, it may be just the whole muscle belly. The muscle belly may be located mainly proximal. Sometimes the muscle belly is reversed and located at the level of the tunnel. So it can compress the median nerve superficial to the tunnel, of course. Yeah, this is one of the anatomical variations that you have to put in mind.
There's another question. Why does ulnar nerve appears hypoechoic at the elbow?
Well, I'm not sure of this, but I think it's related to the arrangement of the fascicle. The fascicle, as Dr. Peter said, they are mingling together. It is not running in one plane. So I think it's the proposition at the level of the ulnar groove and orientation of the even if you are perpendicular, it's commonly to see this, or maybe at this level it is just formed of one fascicle, so you see it as one fascicle. There is theories about that. We are not sure why we see the ulnar nerve. This is, of course, my opinion. So if we have other panelists, they can answer the question, but I think it's related to the number of fascicles and the orientation of the fascicle in its relation with the angle of the probe.
Another question about the circumference of the median nerve, for example. Measuring the circumference, is it of value only at the carpal tunnel level or at other levels?
We usually, there are actually variation for how the sonographers do that. Typically, some sonographers prefer just to measure the cross-sectional area at the level of the inlet, but we usually prefer to scan the nerve along the entire course, along its entire course, starting at the level of the mid-forearm and going distal. And we measure the cross-section. We just observe the area of maximal enlargement, and we measure the area of maximal enlargement at the level of maximal enlargement. We don't just measure the cross-section at the level of the inlet or the level of outlet. We scan the entire course and then measure the cross-sectional area at the level of maximal enlargement and compare it with the cross-sectional reference values, or we compare it as well with the mid-forearm cross-sectional area and calculate the cross-sectional area ratio, which is one of the sensitive criteria to diagnose carpal tunnel. I think Dr. Cartwright will explain that in details in the next lecture about the intraabdominal neuropathies. So I prefer to leave that for the next lecture, I think.
And there's another question regarding the optimum cut-off point for normal cross-sectional area of the peripheral nerves at different levels. Is there any preferred standards?
There are references in multiple resources. There are references for the cross-sectional area in the textbook Neuromuscular Ultrasound book by Dr. Walker and Dr. Cartwright. And you will see, if you just search the Google Scholar or PubMed, you will see many articles about reference values. But of course, we recommend that every lab and every measure, you have to just set your reference values based on in every EMG lab. You have to do your own reference values for being more accurate. And that's why we depend, for example, for the carpal tunnel, we like to measure at the level of the mid-forearm as well and calculate the cross-sectional area to use the patient as his own control instead of depending on the reference values, because it varies from, the gender and the geographic and the demographic data. So you have to create your own reference values in your area. This is the best way.
Good. And there is a question about how to diagnose carpal tunnel syndrome in cases of bifid median nerve.
Yeah, if you have a bifid median nerve and you want to measure the cross-sectional area, you have two ways. If there is no separation between the two bundles, as you have seen in the one of the images, you can calculate the entire cross-sectional area if there is no separation between the two bundles by a fibrous band. But if there is fibrous band in between, you have to measure each bundle, the cross-section of each bundle, and calculate them together and compare it with the reference values or with the, so you should not include the fibrous band in between in your measurement, and you just calculate both and sum up them.
Any experience with elastography to diagnose carpal tunnel syndrome early?
Well, I don't have a personal experience in this. I've read about it, and I think the best one to answer this is Dr. Walker, because I think he has experience in this or interest in this. But there is a growing interest in elastography, not just for muscle spasticity or to measure the elasticity of the muscle, but for the nerve. But I don't think it is, I think it's just still in the research area. It's not applied in clinical practice, daily clinical practice, but it's, for sure the future is promising for elastography. I think so.
Well, I may add, I had some experience with elastography in carpal tunnel syndrome.
Yeah.
It is growing, and it just needs experience to adjust and identify and apply the elastography into the clinical practice. Not yet, as you said, it is mainly for research, but it is a growing area, which I believe we'll see in the near future.
Yeah, I think so.
Yeah. I think that's all for the questions. Nothing more. So
yeah, if
I'd
anyone
like to
has
thank,
any questions, yeah, we have still time. I think I will just have a look if Dr. Cartwright is with us or not yet. So.
I'm here, Dr. Tawfiq.
Yeah, hello. Hi.
Hello.
Hi. Hi.
Hello.
Hello. Hi, Dr. Cartwright. Nice to meet
Good to
you.
see you.
Nice to see you. Yeah, good to see you. How are you?
I'm good. That was a good presentation.
Yeah, thank you.
I can start now. I'm supposed to start at in about 8 minutes. Is that correct?
Yeah, but you can start now if you are ready. So I think, yeah, so we can start. So
okay, let me see if I can share my information.
Professor Yasser, with our moderator, the moderator of our course, will just introduce you. So just give him just 1 minute. So
Sure.
if you don't mind.
While you're adjusting and sharing your slides, may I welcome Professor Michael Cartwright. He's a professor of neurology, Wake Forest School of Medicine, United States. He's a director of Wake Forest Clinics, worldwide expert in neuromuscular ultrasonography, masters in health science research with extensive publication history in neuromuscular ultrasound field. He's also the editor of Neuromuscular Ultrasound textbook together with Professor Walker, and reviewer for more than 20 journals, including Lancet, Nature Reviews of Neurology. His clinical expertise in neuropathy, myopathy, muscle dystrophy, myasthenia gravis. He will speak to us today about sonographic workup of common intrapid neuropathies. Professor Cartwright.
Thank you. Thank you for the very kind introduction.
You're welcome.
Can you hear me fine?
Yeah,
Yes,
I can. Yeah, we can hear you,
good.
Dr. Cartwright.
Good.
Yeah.
So let's see. Here's my presentation. Are you able to see that?
Yeah, yeah, we can.
Okay. Great. I am, let me think here. Okay, I can see the questions, so I can keep an eye on those as the talk carries on. And let's